Dr. Raja, shall we start?
Yeah, absolutely. I think it's we should.
I think
start
people
now.
will join in, no? Because
Sure.
we
Sure,
run
sure.
behind schedule.
Sure.
Okay, fine. So good evening, everybody, and thank you for joining us today. So this, I hope, among in the calendar of events for June, this is the webinar that we have on challenges of controlling visual loss from non-communicable eye diseases from a public health perspective. So we would like to welcome Dr. Clare Gilbert, who's our guest speaker from the London School of Hygiene and Tropical Medicine, who Dr. Murthy will be introducing to you shortly. I'll go ahead and introduce Dr. Murthy, who will be moderating the session today. He's the co-principal investigator at IHOPE. He's also the director at the Indian Institute of Public Health, Hyderabad and Bangalore, and the director at the South Asia Center for Disability, Inclusive Development and Research. He is the professor, Public Health, Eye Care and Disability at the London School of Hygiene and Tropical Medicine. So thank you, Dr. Murthy, for being the moderator, and I'll hand this over to you now.
Thank you, Arnaz. Thank you very much, and it's always an honor and a privilege to introduce my mentor, my advisor, my boss, and we share the same office space at London. So somebody with whom I've worked tremendously and who has helped me grow academically, because I was at the RP Center, but in the typical Indian style, we generally look at cutting corners in terms of documenting things. But it was Claire who's actually made me learn the importance of documentation. And I think that has helped me tremendously over the last few years. If we go back to the first slide, Arnaz, so this is Claire in her Indian avatar, and she keeps saying that maybe in my past birth, I was an Indian. And this is when she was the special guest at my son's wedding in Hyderabad about 4 years ago. So she's going to talk about the challenges of controlling visual loss from non-communicable eye diseases from a public health perspective. Can I have the next slide, Arnaz? So Claire, in my living memory, and it's quite a bit, it's not a small piece of time because 65 years is quite a long period. If I look at somebody who's contributed to developing research capacity across continents, specifically Africa and Asia, and that to South Asia, then I can't think of anybody else who's an ophthalmologist in recent living memory who's contributed to that capacity building. And that is the reason why she is very fondly called as Ma by my African friends, colleagues, because of the effort that she puts into mentoring her students. She was a clinical ophthalmologist before Professor Alan Foster, Professor Barry Jones asked her to go and sit under the peepal tree or the Bodhi tree. And that's when she gained enlightenment that there is more that she can contribute to. And she went and did an MSc in epidemiology, which is one of the toughest master's programs. And one of the first students when she came back from her master's was me sitting there as a public health trained person, troubling her, asking questions, uncomfortable ones at times when she came in to teach, and that was 95. So from 1990, she was at the International Center for Eye Health and was a co-director till last year, when she stepped down as a co-director, but still is the professor at the London School. Next slide, Arnaz. Her work entails research, teaching, and technical support, and she's worked with all the leading international NGOs providing technical support in developing programs. Her main interest has been in blinding eye diseases in children in the lower and middle income countries. And her major focus of research have been, in addition to that, have been glaucoma, cataract, diabetic retinopathy, and refractive errors. Like I said, she's been a technical advisor for a large number of organizations, including the Vision Impact Institute, USAID, Child Blindness Program, that's the USAID program, the World Sight Foundation, Queen Elizabeth Diamond Jubilee Trust, and also the VLEG Foundation, which Claire forgot to mention. Next slide, which is the last slide. So in terms of her outputs, 350 peer-reviewed publications and 27 book chapters is no mean feat. And it's really an honor to have been part of that writing process on a number of those publications. She has received a number of international awards, including from the ICO, the American Academy of Ophthalmology, the Royal College of Ophthalmology, and most recently, she's been awarded the honorary fellowship, and therefore she's the honorary fellow of the Royal College of Ophthalmology. So that is Claire for you in brief, and her work she'll try and encapsulate in her presentation. So over to you, Claire, and thank you very much for accepting to speak today.
Thank you very much indeed, GV, for your very kind words. And I've forgiven you the troublesome questions 26 years ago. Thank you very much for inviting me to give this lecture, and it's a real privilege and an honor to do so. And in a way, I feel that I'm preaching to the converted, because I know that LVP is a real pioneer in thinking about the eye health needs in populations, in communities, and has developed many strategies and approaches which one could call public health approaches. But I think it's quite useful to think very broadly about public health, which goes beyond programs and services. And this, I hope, will highlight what some of those other areas are. I've not actually focused on the challenges. I've really rather rephrased it as what can be done. And then right at the end, I've just highlighted that there will be challenges ahead. There are currently challenges, but they can bit by bit be overcome. So I'll give a very brief overview of public health, just really to highlight the very broad scope of what we mean by public health. I will give you an update on the epidemiology of visual loss from cataract, diabetic retinopathy, and glaucoma, using the latest data from the vision loss expert group and the global burden of diseases. They reanalyze the data, which they do periodically. They update the data with new surveys and reanalyze the data for the current situation and also projections for the future. I'll then focus on 3 non-communicable eye diseases: cataract, diabetic retinopathy, and glaucoma. And I focused on these because issues around uncorrected refractive error and cataract are really fairly similar. Diabetic retinopathy and retinopathy of prematurity, which is also a non-communicable disease, again, the strategies and approaches are, they're parallels. And then I'll follow up with glaucoma, which really, I think, is the big challenge from a public health point of view. And I'll highlight what some of those challenges are. And then I'll finish off by talking a bit about policies and universal health coverage as a way of kind of bringing everything together. So public health refers to all organized measures to prevent disease, to promote health, and to prolong life amongst the population as a whole, regardless of who is delivering those measures, whether they're the public, private, or the not-for-profit sector. And the key thing here is it's for the population as a whole. It's not just for people who are sick. And that's because a major function of public health entails preventing disease through health promotion, specific interventions, and so on. And the provision of clinical services is one component of public health. It's a very important component, but it is not the sole component. And public health has been defined and described in a variety of different ways, and it has several interconnected elements, which are illustrated here. And they can be summarized into these 6 different areas, really. First of all, any public health can only be based on an understanding of the health needs in a population. And because everything else flows from that, determining the magnitude, setting priorities, deciding which services are needed, it's all based on the needs in the population. And so robust epidemiological quantitative data is really a basic building block of public health. And I think in India, you're pretty well placed with population-based data on the prevalence and causes of visual impairment and blindness in adults, some data in children, and then there is an age gap really from adolescents and young adults. That's an age group which is often missing. It also entails health services research to assess needs and service use. So is there a match between the services that are being provided and the needs in the population? Public health also ensures that services of high quality are in place, which address the priority health needs with evaluation of their effectiveness. And I put an asterisk down the bottom to remind me to say that health systems require 6 essential elements: a health workforce, technology and infrastructure, governance and leadership, financing, health management information systems, and technology. So all those things have to be in place in order to deliver services. Another aspect of public health, a very important one, is the development of policies and guidelines. And policies are really just decisions that those who have control over resources make on how those resources will be allocated. And I think in international eye health, we've been really fairly slow on understanding the vital importance of government policies and of policies from organizations like WHO and UNICEF, who can be very influential in terms of the decisions governments make on their health expenditure, including eye care. This whole lecture could have been just on policies, but policies is just one very important part of public health. Another element of public health, which I think eye care is not so good on, is health promotion. And this is to try and prevent people developing eye conditions by addressing the underlying causes. And I will outline what those underlying social determinants are in a moment, and really engaging communities and increasing the health literacy of communities. And by that I mean so that they understand how to keep themselves healthy, they understand what symptoms might mean, and they understand what the appropriate action is to take if they become ill. And we're really, I think, not that good at doing that on the whole. Advocacy is needed, and in this document I saw it just said advocacy for law enforcement, but actually you need advocacy across many of these areas. Even if there are policies, they may not always be implemented, for example. And so advocacy by service providers say, hey, look, you've decided in this policy, you as a government say this, this, and this. This is not being implemented. And then research sits in the middle in this diagram because it's really cost cutting, and all these different areas there are research questions which are generated. And this is why being involved in international public health is so fascinating, because you need the whole gambit of research designs, from quantitative surveys, clinical research, health systems research, health economics, social science, etc., etc. It's a very long list of the different types of research that you need to really build a strong public health system. I will refer to this diagram as we go through, and to see how the different components may be of relevance to the non-communicable, those 3 non-communicable eye diseases I'll be focusing on just as examples, really. So an update on the epidemiology globally of visual impairment and blindness. So the number who are blind, as you'll see there, is 43.3 million, just over half are women. Moderate and severe visual impairment is nearly 300,000, again, over half are women. And mild visual impairment, which is less than 612, but able to see 618 in the better eye, is another 260 odd million, again, more women than men. Mild visual impairment has recently been added by WHO, and I think it's very useful because 612 is around the level of vision that you need for driving and for many occupations or tasks that need reasonably good distance vision. There's another 865 million people with uncorrected presbyopia, and this is excluding those who have distance visual impairment. So these are people who just have presbyopia, uncorrected presbyopia. So that's nearly 1.5 billion people. Sorry, it says I've put millions. Nearly 1.5 billion people. That's more than 1 in 5. And what this does not take into account are the people with chronic eye diseases who need services to prevent them from losing vision. So that's all those people with glaucoma, and it's all the people with diabetic retinopathy who are at risk of visual impairment. So the task is enormous. And I think when people see these numbers who aren't aware of eye care, and indeed when people first visit eye hospitals, they are just amazed at how busy they are. It's really not just getting the priority it deserves. And you'll see that these latest figures are published in the Lancet Commission. And for those of you who've not seen the commission, I do recommend that you look at it. It's a very comprehensive, very evidence-based document, which was led by Matthew Burton, who is now the director of the International Centre for Eye Health. And GV and I were fortunate enough to be a part of this really excellent body of work. So if those numbers aren't big enough already, then they're projected to increase because our global population is growing, but it's also aging. And this means that non-communicable diseases are going to become more frequent. These 2 graphs also come from the Commission. The one on the left is the age standardized prevalence of blindness and visual impairment in those 2 different categories. And you'll see that Southeast Asia has the highest overall prevalence at 11.5% or so. That's 1 in 9 people. And the number affected, also Southeast Asia, that's a combination of the high prevalence and the very large population in South Asia. These are projections of visual, up here is mild visual impairment, moderate severe visual impairment, blindness and uncorrected presbyopia for men and for women. And you can see that the projections are increasing really quite rapidly for all those conditions, more so for men than for women. We don't have time to go into the gender differences, but there is a lot of evidence to show that some conditions, when you disregard age, are more common in women. But women do tend to live longer than men, and so they are more likely to develop blinding eye diseases, and also they are far less likely to access services. So there are those three things: a higher incidence, greater longevity, and less access to care. Those are the three main drivers of the excess blindness and visual impairment in women. This rather busy graph is the causes of blindness on the left and moderate and severe visual impairment on the right. The red bars are other conditions, and this is a huge mix of a large range of conditions which are not the ones that are listed here: cataract, uncorrected refractive error, glaucoma, age-related macular degeneration, diabetic retinopathy. And if you look at the bar at the bottom, this is the global figure. So globally, around 62–63% of the population are blind from these 5 non-communicable diseases, whereas it's over 85% have these conditions, those who have got visual impairment. And if we look at South Asia, we see that it's around 72% of blindness is due to these conditions, and around 85% is of a mild and moderate visual impairment. So a big issue in Asia. So just reiterating what I've just said, and you can group these diseases really into 2 categories: cataract and uncorrected refractive error, diabetic retinopathy, glaucoma, and age-related macular degeneration. And this is because the diagnosis of cataract and uncorrected refractive error is really fairly straightforward, and it's not very resource intense in terms of skill or specific equipment. And the resources for management are also moderate or low. You need skilled ophthalmologists, obviously, for cataract surgery, but the surgery is very cheap, so the unit cost is really very low. And it's the impact is immediate. Next day, as soon as someone puts their glasses on, their sight is restored, usually nearly to normal. On the other hand, diabetic retinopathy and age-related macular degeneration, glaucoma, are very high resource in terms of diagnosis. You need more sophisticated equipment, and you need more skilled personnel to be able to diagnose these conditions. Resources for management is also much higher. You need lasers, expensive drugs, and the other big cost is the need for ongoing follow-up and lifelong care, which increases the costs massively for health service providers as well as patients. And the impact is low as far as the patients are concerned, because the aim usually of managing these conditions is to prevent visual impairment or to reduce the progression of existing disease. And that means so the cost effectiveness is much lower than the cost effectiveness of cataract surgery and correcting refractive errors. So this is why I've chosen cataract in the top row and diabetic retinopathy and glaucoma in the second group of diseases. So earlier I alluded to the social determinants of health, and WHO has been thinking about these for some considerable time, and a lot of work has been done in the UK by someone called Marmot. You may know his name. And these are the factors which promote health. And if you flip it over, then well, some of them is actually positive and some of them are negative. So it's, forget what I just said. We all know that poverty is likely to increase people developing some kinds of diseases. And because they can't afford care, then they are less likely to be treated to prevent disability or to restore function. We also know that education is very important. It allows people to read materials. Educated people are also usually slightly wealthier. And so health education and health promotion is much more amenable, it's more accessible, they're more likely to be able to understand it, and so on. Unemployment and job insecurity contribute to poverty and to stress, and stress really is very interferes with people's cognitive function and makes it difficult for them to make rational choices. And there's a lot of research on this. So poverty or any stress means that people don't function as well cognitively as people who are not under stress. Working life conditions, again, that can lead to injuries or disabling conditions. Food insecurity, nutritional deficiencies, people eating the wrong kinds of food, housing, basic amenities in the environment, again, lots in there, dust, dirt, heat, lack of water, lack of sanitation, overcrowding, etc. Early child development means that someone can start off on a lower trajectory and never reach their biological potential, which means that aging decline is going to have a greater impact on them later in life. So taking a life course approach. If people are discriminated against, then they may not be able to access care, conflict. We all know what that impact that can have. And affordable health services of decent quality may not be available. And then more recently, commercial determinants have been added, I think due to the huge impact of marketing by the food industry, by the pharmaceutical industry, and the impact this has on people's behavior in terms of what they eat, how much exercise they take, etc., etc., etc. So a very, very, very broad brushstroke. And I'm just going to illustrate this with some analysis that I've done with Jackie Ramke using data from national surveys in Pakistan, Nigeria, and Sri Lanka. This graph is a little bit complicated, so I'll just explain it. The numbers, the proportions you see along the bottom represent the proportion of the sample in each of these groups. So this group here is illiterate rural women, and that was 32% of the population. 13% were illiterate urban women. And here you've got literate rural women and literate urban women, and the same for men. Oh, sorry. This line here and here gives the overall prevalence of cataract blindness by sex, and this is the men box, so this is 1.6%. And then at the top of each column is the prevalence of cataract blindness in each of these subsets of the population. So this is the Pakistan data, and next to it now is the Nigeria data. And the bigger the box, the size of the box represents the magnitude, the number of people affected. So the two biggest boxes in both Nigeria and Pakistan were amongst illiterate rural women, were much more likely to be cataract blind than any other subgroup in the population. And I can't exactly remember the figures, but I think in Nigeria, this is 45% of the total. And in Pakistan, this is a little bit less, which you may find surprising. But Pakistan over the last 30 years has had a really excellent prevention of blindness program. And they have built eye care services district by district by district, training ophthalmologists, equipping them, building operating theatres, training and appointing managers. And I think this really shows that access by rural women is higher than one might anticipate. So this is showing some of these social determinants by place of residence and by literacy education. And this now is looking at marital status. GV was also part of this paper. And so this is now men and women again, married, not married, married, and place of location. Again, distribution of the sample in these different groups and who are most likely to be cataract blind. And the largest box in both these studies were the rural, not married women, again, contributing. So this is showing the importance of marital status. And most of these were, the vast majority of these women were widows. And then that raises a whole tranche of cultural and social questions about how these women access care. If they haven't got a husband, then who's their head of household? Who's going to pay for them to travel, to stay, and for hospital fees, and so on. So I think these analyses combining these social axes really highlights which groups in the population are really marginalized and gives us information on who should be targeted. How one goes about targeting them is another question, which I'll come on to in a moment. So what are the public health approaches to controlling visual loss from cataract? So as I've already said, combining these social axes really highlights who is less likely to access cataract surgery. And to really understand barriers to access, high qualitative research is really, really needed. Be that in-depth interviews with people who are cataract blind, maybe including their family members, the head of the household, the village elders. You might think of using focus group discussions and so on to really try and unpick all the different factors which influence health-seeking behavior. So these may involve the broad environment, including distance, terrain, roads, access, transport, etc., as well as the policy environment. And then the next level down would be cultural and social factors which impinge on people, particularly women, maybe the status of women and of widows and the elderly in general. How much standing do they have? And then within the household, how healthy is the household? Who makes the decisions about the use of scarce resources? This is a very difficult challenge that all poor families face. And what's the household composition in terms of age and gender? And is it a blended family, a mixed family, extended family, and so on? And then you come down to the personal. So what's that person's beliefs about why they became ill? Is it God's will? What fears do they have? And agency in particular, how much freedom do they have to make choices about their own lives and their own health? And so really, to really understand this, and it's understanding these barriers, which is then what leads to coming up with strategies which may help to improve access, is what is really needed. So no more KAP studies, please. They don't give you the richness of the information that you need. So reducing cataract blindness, we can think about prevention, but scope is limited. Smoking cessation, that's been shown in high-income countries to reduce the incidence of cataract needing surgery, and reducing biomass cooking for fuel. In India, there are several studies which suggest that increases the risk of cataract. And then increasing the efficiency of cataract surgical services and increasing access. Now, giving a talk to LVP, I don't think there's anything I can say at all about improving the efficiency of cataract surgical services, because LVP and Aravind are just leaders in the world in this. One thing did occur to me when I went to another NGO hospital, and they were talking about this huge seasonal variation. I wanted about varying the fees by season to see if that can be flattened out to encourage more people to come during the summer when the demand is normally lower. DACO surgery, simultaneous bilateral cataract surgery, there are several trials on this now demonstrating that it's safe, or same admission bilateral surgery. This reduces costs to patients, and it also reduces costs to providers. What about strategies to increase access to cataract surgery by marginalized groups? I was involved in this systematic review, again by Jackie Ramke, and after an extensive review of the literature, she looked through nearly 3,000 abstracts and only found 2 studies, 2 randomized trials, both from India. They used a range of different interventions such as free surgery, transport, more detailed health education, and so on. But the findings were really inconclusive. And more studies are really urgently needed, using a combination of different context-specific strategies. And most behavior change interventions, because after all, this is what we're trying to do, is to make people realize they have a problem, it can be treated, where to go, and to allay their fears, and etc. It's all about hearts and minds and changing attitudes, as well as practical things like providing transport and maybe an escort. Those things are have to be very context specific and may even vary in different parts of India. And this is where the qualitative research can really, really be very helpful. And again, discussion with communities about if they've got some elderly cataract blind women in their village, what could they offer, what could they suggest as a way of helping those women to access care. They may well come up with interventions that us sitting in hospitals may never dream of. And so this is a big area of research. Cataract blindness is still nearly half of all global blindness. It's a higher proportion than that in South Asia. And I think it is something that has been neglected and is really urgently is needed. Okay, what about some of the other public aspects? I've talked about the qualitative research to assess barriers. I think the IHOPE project can help to really dig into a lot of the things about who are accessing services compared to who in the population are cataract blind, what proportion of those referred attend, what are the outcomes, etc., etc., etc. So that will provide a lot of very useful information to see where there may be blockages in the pipeline, or people drop out, or whether some things along the line can be tweaked to improve access. Ensure quality services are in place. There needs to be an expansion and the provision of surgical services to rural areas. Quite how that will happen, I don't know whether India would ever consider training non-physician cataract surgeons. Probably not. Some countries in Africa do that. They are very carefully trained, very carefully mentored, and they can most definitely provide services where others are not willing to work, or providing incentives for ophthalmologists to work in rural areas. Using evidence to develop policies, yes. For example, which is the most effective health financing mechanism for cataract surgery. And I've also, there's lots of evidence that could be used for guidelines as well. Health promotion, again, is needed, and again needs to be based on local understandings and health-seeking behaviour. I don't know whether there's any legislation in India about the sale of topical steroids. I don't know whether there's any questions being raised about smoking cessation in public places. I guess these things would be very difficult to implement and to regulate, but I just put them there as examples. And research, yes, I've already mentioned that. Okay, diabetic retinopathy. Diabetic retinopathy is an increasing problem in India, as I'm sure you're all aware, largely due to the increasing prevalence of diabetes, which on the side on the map on the left is the prevalence in 2016, and the graph on the right is the increase, and the red and orange show an increase of over 36% increase in the prevalence of diabetes. Added to that, one has to recognize that it's the duration of diabetes, which is one of the key drivers of diabetic retinopathy. And the epidemic in India started maybe 20, 30 years ago. And that means that there will now be people who've been living a long time with diabetes, and their risk of diabetic retinopathy is greatly increased. You're all aware of the risk factors for diabetic retinopathy. including poor control of blood glucose and hypertension. Hyperglycemia is a bit more controversial. There's only one trial undertaken of lipid-lowering agents in India. And although that study did show an impact on progression, unfortunately, it was not a big enough trial to give statistically significant findings. So if anyone wants to investigate hyperlipidemia, that should say, really sorry, hyperlipidemia as a risk factor in a trial, then I think that would really help to open another avenue for control, which at the moment hasn't probably received the attention that it should. And pregnancy also increases the risk. The data on the proportion of people with diabetes who have diabetic retinopathy or macular edema, these data are from the studies that have been done in India. It's quite variable depending on the timing of the study. Some of these were done longer ago, and the location of the study as well. And some studies did or did not report diabetic macular edema. The number of people with diabetic retinopathy nationally is, with any diabetic retinopathy, it's somewhere in the region of 10 to 13 million. And with vision-threatening retinopathy is somewhere in the region of 3.5 to 4.5 million. So a huge problem, and one that will increase in the future. If we break it down to a district, it becomes a little bit more manageable. So the number of people with vision-threatening diabetic retinopathy in a population of 1 million is around 2.25 million to just 1,000 to just over 3,000. So that's a number that you can kind of get your head around, and could imagine 1 or 2 service providers being able to manage. So the strategies for control of visual loss from diabetic retinopathy are to reduce the risk factors for diabetes, so health promotion, exercise, diet, reduce the risk of complications, and promote adherence to medication, early detection of vision-threatening diabetic retinopathy by screening, followed by high-quality management and follow-up. I'm not sure, Julie, whether you've given a presentation to LVP about the Queen Elizabeth Diamond Jubilee Trust program in India. I'll just very quickly run through it because it absolutely used public health principles. There was very extensive advocacy with national and state ministries of health, because we realized that most people with diabetes attend government facilities to have their blood glucose measured and to collect their medication. And so any screening had to be integrated into those services as a way of making it scalable and cost effective, rather than a standalone separate activity. The capacity of government ophthalmic assistants was built because they took the images using a Forus camera, and then dedicated software was used so that the local ophthalmologists, who'd also been trained, could read the images. And screening for diabetic retinopathy was integrated into services at the primary and in some cases the secondary level for type 2 in around 50 centres in 11 states, and for type 1 in 4 centres in 4 states. So the government eye care services were strengthened to diagnose and to manage vision-threatening retinopathy and DME. This required capacity building by organisations such as LVP. So the governments were partnered with an NGO who did the training and ongoing mentoring. And that seemed to work very well in most places. There was a big emphasis on prevention as well. And so GB led the development of a training course, which was an interactive course for physicians on how they could better manage diabetic retinopathy and to find out more about diabetic retinopathy and screening. We constantly monitored the program using the software that was developed for it. And there was a midterm review, which enabled us to identify by an external evaluation team what we needed to address for the latter part of the program. And then there was an end of project evaluation. operational research was embedded into the project, such as an evaluation of peer support groups, and national operational and evidence-based technical guidelines were also developed. So as you can see, these should be ringing bells with quite a lot of those public health components that I was talking about earlier. And the outputs were around, or you can read those there, the number of people who were trained or orientated, and over 56,000 people with diabetes were screened at least once, and 4% were treated for vision-threatening diabetic retinopathy or diabetic macular edema. And towards the end of the program in 2019, several of these states had planned to scale up services, and GV and I had planned at the end of last year, 2020, to go back a year later to see what services had continued and why they had continued, and to see which services had stopped and why they had stopped, and whether plans for scaling up had been realized or not, and again, why. And this would have been a wonderful sort of finale to this very intensive period of work, because a lot of lessons, I think, would have been learned from what happens when funding ends. And this is a very under-researched area. But the approach we took to integrate, we hope will be sustainable, or more sustainable than if it had all been a vertically, sort of externally funded program. Again, I'm just going to whiz through all these because I'm running out of time. Again, epidemiological, all those different types of research are needed. And I think the IHOPE database and the RVP data, rich source of information about diabetic retinopathy, including evaluation of the technical guidelines, or validation of the technical guidelines, if you like.
5 more minutes.
Okay. There's really a need to expand the integrated screening and treatment to other states and districts. The whole health financing needs to be looked into with policies that cover that. And again, the health promotion piece is key and very important. Much more research, there's potential for much more research in diabetic retinopathy and how it can be approached from a public health perspective in India. Okay, glaucoma, I'm going to be quicker about this. There's lots of reasons why it's a problem. In Africa, they call it the silent thief of sight, which I think is a very good term. It doesn't cause symptoms early. And in all countries, a very high percentage of people identified in surveys with glaucoma do not know they have the disease, a frighteningly high number. Open-angle glaucoma is more aggressive in Africa, starts earlier, so it's much more blinding. And there's no single diagnostic test with high levels of diagnostic test accuracy at the moment. And this is really one thing that is really hindering having a public health approach, and it requires lifelong management. Patients often present late, often already blind in one eye. It's a very difficult disease for patients to understand. Low adherence to medication is a global phenomenon, and many patients are fearful or reluctant to have surgery, which is often on their good eye, to preserve that eye. High lifetime costs, and follow-up can be very low. A study in Nigeria showed that 75% of newly diagnosed patients had either completely failed follow-up or had not been seen for 9 months since the time of the study. So a big problem. Providers also face challenges. Medication may not be available, too few specialists, lasers are not widely available, and it really puts a very heavy demand on outpatient departments. So I think for glaucoma, we need to turn everything on its head and start with research. Rather than embedding research, I think we need really good research to determine what is the optimum primary management of glaucoma, and this needs to be context specific. For example, in Africa, people present late, it's an aggressive disease, they can't afford medication, they don't come back for follow-up. Laser as a primary treatment seems to be the way to go. And we're now doing a series of studies and randomized controlled trials to try and find out which is the optimum form of laser for primary treatment. High quality services which are efficient need to be in place. There's often a lot of inefficiency in glaucoma clinics, people moving from one place to the next. And this is one reason why people drop out. There need to be care pathways and protocols, and basically there need to be more services made available. Opportunity of case detection by looking at the disc should be routine at every level in where you've got eye care personnel. And we need more research into the diagnostic test accuracy of affordable technology for earlier diagnosis, which can be integrated into primary care. That is key. And all these things need to be pilot tested to see which is the best approach and model to use before we can really advocate public health approaches. Okay, primary eye care is the detection and management.
2 more minutes, Claire.
Eye conditions, thank you, Julie, at the primary level. Primary eye healthcare, which I think is what we should now be talking about, includes health promotion. All that stuff about prevention and health literacy must be included as part of primary health care, primary eye health care. General approaches, integration is absolutely key into primary healthcare policies so that non-communicable diseases can be detected at that primary level and then referred. This is fairly straightforward for cataract, uncorrected refractory and presbyopia, more challenging for diabetes and diabetic retinopathy. Integration of visual acuity measurement into policies and programs for care of the elderly and non-communicable diseases, good referral systems, health management information that include eye conditions, and appropriate health promotion materials. More services everywhere. We haven't got time for that. Just lastly, you may be aware of WHO's Universal Health Coverage Initiative. I'm just going to move on. But basically what they're doing is developing evidence-based packages for priority eye conditions for ministries of health, which includes all the equipment, the technology, the consumables, the trainings, the skills, and the costing of all of that. And ideally, all this will be put into national strategic health plans for eye care, so that eye care sits alongside all the other diseases. And I think this already happens in India, but in many countries, in other countries, eye care has its own prevention of blindness plan, and it never gets included when ministries of health are making important decisions, policy decisions about training, deployment, providing equipment, and so on and so forth. So hopefully universal health coverage will really help to make a big difference going forward. Right, I shall stop there.
Thank you very much, Claire. I think a round of applause for that wonderful presentation. And from what Dr. Raja had mentioned at the beginning, if I look at the number of attendees, so I'd say it is mean plus 2 standard deviations above that. So we've done well in attracting attention for Claire's session. So there have been some comments which I'd like you to respond, and then I'll also look at some queries that I would ask you also. So one of them that has been raised is that, given that the problem of presbyopia is huge, like you've shown, and that COVID has changed the lifestyle to, say, digital utilization or remote services, whether it is for food or for banking, payment services, etc. Do you expect uncorrected presbyopia to affect daily activities more than earlier? And if so, how could we scale up correction of presbyopia in the rural population?
I definitely agree that the demand for presbyopic correction will increase, largely due to these things. Everyone now has access to a mobile phone, and if you can't read that, then you're really disadvantaged. I would like to see the provision of presbyopic correction being part of primary eye health care. There would need to be lots of regulatory frameworks around that. I know that there are, in all countries, you can buy presbyopic correction over the counter in chemists and in boots and in marketplaces. And while that does increase access, it is a missed opportunity for people to have an eye exam to detect other eye diseases. And I think it's a really difficult balancing act between the perfection of that and people really not having access to presbyopic correction. And it may well be that if people buy glasses, buy presbyopic correction from the market or from primary care, they get to value them. And the next time they need a replacement, they may go to see an optometrist if they're available. Because I think the likelihood of getting optometrists in every small town or every village in the near future is vanishingly small. And that applies globally.
True. Another question for your consideration is the fact that a lot of people have been advocating for screening at physician, diabetologist level, and that the ophthalmologist should play a supportive role to the physician and diabetologist. And the fact that we have done well in terms of screening for diabetic retinopathy when it's in a project mode, but a systemic approach or a systematic approach is generally lacking. How do you think general practitioners and diabetologists are to be involved? What are your thoughts on this? I know you've presented some of your thoughts on this, but does this need to be strengthened further and carried forward, moving the diabetic retinopathy screening services away from the eye clinic into the diabetic clinics?
I think it's a must. I think if screening just happens in eye departments and eye hospitals, that's only going to touch the tiniest tip of the iceberg. It has to be integrated into the places where people with diabetes receive their care. And I think artificial intelligence is really going to make a massive difference here. Once there are really robust systems and affordable imaging devices and valid algorithms for the Asian population, I think that really, really opens the door for screening at massive scale. The next problem will then be, are there enough clinicians to actually do the confirmatory diagnosis and to deliver the treatment that's needed? Because it's not ethical to tell someone they've got a problem if you can't then back it up with the services that are needed. So I think this is a tsunami that's around the corner, because AI for diabetic retinopathy and DME is around the corner. So I think this is an issue that's going to be upon you in the next.
Before you realize it.
Yeah.
And I think recently I had submitted a paper, and the confusion in the reviewer's mind was a lot of models exist for DR screening. Then I had to emphasize that systematic screening is different from a project mode, just like Dr. Raja highlighted here.
Yeah, absolutely right.
On glaucoma that we have from one of the listeners, there is a large gap between the prevailing burden of glaucoma and the services being delivered to prevent it compared to other leading causes of blindness in India. Considering the magnitude of the problem, as well as the associated disability, what public health measures may be taken to reduce glaucoma burden? You've actually presented views, but I'd like to add something which may be more India specific, because you have an understanding of India.
Yes, I do, I suppose. But what I would like to see is the much, much greater use of lasers based on evidence from trials. I'd love to see some large multinational trials of laser treatment as a primary treatment for open angle glaucoma. really well done, rigorous, including patient's acceptability, including cost effectiveness, to really get robust evidence, because we know patients don't use their drops. They may remember the day before they go to the clinic. They then get put on Diamox, or they're given a second lot of drops. All the hassle of having to buy the drops every month, putting them in every day, remembering. I've seen videos of people who were filmed by an ophthalmologist. She said, "Show me how you put your drops in," and it was horrifying. One person went like this and was scrubbing them on the cornea. Another one that just literally went down their face. It's really, really difficult. You need another family member.
Right.
So I really think lasers are the way to go, wherever you are. In the UK, they're becoming much more popular now too. We just need to know which modality.
Thank you, Claire. Yeah, and I think it answers Dr. Sonia's question. Another question from Dr. Brijesh. What are your thoughts on developing a national regional registry for diabetes and diabetic retinopathy based on experience of the NHS or any other screening systems?
Oh, I mean, that would be wonderful if possible. Our system really works pretty well. It's a separate system in Scotland and in the UK. The screening is done by technicians or by optometrists. We've got a kind of dual approach. And the images are read centrally. Again, I'm sure when AI comes in, that step will be missed. And there is a dedicated software platform for all of this. Yeah. I mean, the big difficulty with any screening program is recalling people and getting results back to them. So if there's any delay, if someone doesn't know at the time what's wrong with their eyes, and then that adds another large admin burden, is getting the finding of the screening back to the patient. And I think this will be another massive benefit of AI.
Thank you, Claire. Then your very own student, Rajan, has a query for you. And, you talked about diabetic retinopathy, glaucoma requiring high skill and intense high-level equipment to screen and diagnose. And these are also, in a way, silent diseases. And if screening has to reach the rural areas, what would be the way forward in solving this paradox? Can we look at how strengthen the frontline health workers in primary health care to play a role, even if they have less equipment at their disposal?
I think really there is a need to make sure that the government system, where you have the ophthalmologists at the lower level, which would be the lowest place? Is it community health centers?
Yeah, the primary health centers and the sub-centers. So
no, but you don't have ophthalmologists at that level, do you? But you do.
No, you have an ophthalmic assistant at the community health center level.
Yeah.
And the vision center, which is looking after 50,000 population.
Yeah, but where's the lowest in the system you get the ophthalmologist? That's in the community?
Mostly at the district hospitals.
District hospital.
It's at the community health centers also, but both at the district hospitals.
Okay, well, I think there's a real need to build the capacity of the district level ophthalmologists, which we were able to do. That's what happened in the trust program, wasn't it, GB? It was district level ophthalmologists who were trained to, they didn't always interpret the images, but they were trained to diagnose diabetic retinopathy and some of them were trained to also treat.
Laser, yeah.
With laser. With referral.
So, one more question from the listening in audience, and then I'll just keep the last word for myself with a couple of questions. So one was in terms of what is your opinion about peak acuity app for screening refractive errors in low and middle income countries?
Okay, thank you. Thanks for that question. First of all, I think it's very important to realize that Peak is not just an app. It's a whole health management information system tool for school eye services or for community eye health services. because a very key part of it is the networking of information, which is taken at the primary place where the patient presents. So either a child in a school or a community member. Those who fail the screening, visual acuity screening, their details then go up to the next referral system, and the PEAK system will send a reminder message back to the person or to the child. And so it's actually a system with feedback loops. It's not just acuity. In terms of visual acuity, it's been validated, and I'm sure it's absolutely robust as long as it's implemented properly, but that's the same applies to any acuity measurement. So the validation is very robust. Yeah.
Because that is very important, that it's just not an app, but
no,
it does much more.
Much more.
Let me, in the end, put some pure public health issues in front of you for your response. So one is the fact that you've talked about the universal health coverage, which also then links into the sustainable development goals, where reduction of NCD mortality by 50% is one of the key indicators. Eye diseases don't cause mortality, but is there an opportunity for advocacy with the SDG agenda to put eye care in the, the forefront, if not the forefront, at least in the main problems that need to be considered when we are looking at SDGs?
Absolutely. And this is one of the main thrusts of the Lancet Commission, is saying that eye health is a development issue. And this is because of the impact of visual loss on early child development, academic achievement, productivity in the workplace, increase in falls and fractures, increases in road traffic accidents, etc., etc., etc. So visual impairment, well, you need eye health to contribute to achieving a very large number of the SDGs. So it needs to go on the development agenda. And I think there has very recently this year, following the Lancet Commission, there have been a series of very high level UN WHO meetings. And this is where, because of COVID, we're all socially isolated and we haven't been able to meet together as colleagues. So I haven't been kept up. I'm not sure what the current situation is with regards to Matthew, but I know that they were hoping for a UN declaration on this. So
excellent.
Yeah.
That would really be helpful, because otherwise we miss the NCD bus, because they go full steam forward and we'd be left behind.
Yeah.
Another issue you mentioned about social determinants. We find that when we look at research studies, a lot of people try to collect data on social determinants from hospital-based data or questioning in the hospital. What do you think about that? Is it the right approach if you want to look at social determinants, that you could use the hospital as a proxy, or should it all be population-based?
No, you can't use it as a proxy. I mean, basically, in the community, there are people who are, let's take cataract blind. They will come from all walks of life, varying age, men and women. But as I showed in that earlier slides from Nigeria, Pakistan, and Sri Lanka, subsets of the population are most at risk. And if you combine social axes, you can work out who they are. If you have hospital data, you will only collect that data on people who come, and you don't know who hasn't come. If you know who in the which subgroups in the population are the most marginalized, you can then check that against the people who are accessing services. So let's take that example of 30% of people in, I can't remember which one it was now, was it Pakistan?
Yeah.
Nigeria were illiterate rural women. if 30% of people coming for cataract surgery are rural, illiterate women, that's very useful to know, because you know then that your services are accessing even the most marginalized. So it's important to collect, but it's only meaningful if you relate it back to who in the population needs the services. The both together are very important.
That's very, very important, because a lot of people have that confusion, and they forget that not everybody is able to access certain services. That's very important as a message. And one more thing that I would like you to use this opportunity to give a message is that most clinical researchers are concerned about the numerator, whereas most public health experts are more worried about the denominator.
Yes.
Being a public health person, I think the denominator is critical whenever we are talking about any rates or we want to make any difference. What is your understanding on that, and how can we get that message across to clinician researchers?
Well, I just asked them the question, if someone is dying and leaving you their will, would you prefer to have a half of their money or a quarter?
And that you
The one's the same. One's on the bottom is 2 and the other is 4. The denominator, right? They're both important, but as much rigor has to be given to getting the numerator right as the denominator. They're both equally important, so you end up with the right proportion.
Yeah, but when we look at comparing trends, I think the denominators are critical, because if we just compare based on the numerators, there could have been so many other
Yeah. Completely agree.
There would have been a problem.
Yeah, I completely agree. Yeah, see what you're saying. Yeah, yes.
So there were some more comments which talked about appreciating this wonderful talk and enjoying this session. So because of time constraints, I can't, go on and on. I'd love to do that. We do that many a time. But on behalf of the entire IHOPE team, Dr. Raja as PI, Dr. Rohit, Dr. Arnaz, who's been the main coordinator, IIM Ahmedabad, IIPH Hyderabad, and LVP, I think all of us want to thank you for taking the time out immediately after your short vacation and be talking to us on an academic platform rather than on your holiday experience. Thank you so much from all of us. And if I wants to mention anything to wind up, over to you, Arnaz. Otherwise, thank you once again, Clare.
I would like to thank Dr. Clare Gilbert and Dr. Murthy for this wonderful presentation and moderation. We had lots of questions. We were worried whether we'll have enough interaction. I think we had a lot of interaction, raising important questions, and Clare has given us enough to think about for IHOPE. And also, I can tell Clare here right now that we will definitely take up your questions as research projects. Also looking forward to seeing you again soon for the advisory board meeting. Thank you all, and have a wonderful evening.
Thank you.
Thank you very much, and namaste, Clare.
Bye-bye. Thank you.
Bye.
Thank you. Bye. Have a good evening, Clare.
Thank you, and to all of you.
Yeah, and Dr. T.P. Das has also sent in his greetings to you. And
I can't see any of the chats for some reason.
yeah, so that's why I'm reading out the chats for you.
Okay.
Many thanks, Clare. Many thanks.
Great pleasure.
Thank you very much, and back to you, Arnaz.
Yeah, thank you. Thank you very much. Thank you,
Bye.
everybody. Bye-bye.
Take care.